In every section, there's a part that comes where you simply talk about supportive things that are not necessarily tested directly, but used as an association or part of a clinical vignette. So let's talk about the weakening of the vessel wall in the cardiovascular system. Here we have aneurysm and we have dissection. Dissection is high yield, as I explained earlier. They're going to test anything that has to do with the etiology of dissection, the method of treatment, as well as the modality of testing of dissection. You have a true and a false aneurysm. Essentially, you're saying is which part of the things that make up this tube, which is a vessel, which part of that gets to become part of the aneurysm. So in true aneurysm, you have all three layers will be part of it, and usually you see that in things like buried aneurysm. False aneurysm, you only have parts of the vessel wall that become part of the aneurysm. Let's talk about some of the things that may cause aneurysm. Syphilis, again, we said tertiary syphilis specifically may lead to aneurysm as well. We said atherosclerosis can also lead to aneurysm. In tertiary syphilis, the etiology is usually you have an obliteration of the vasa vasorum. These are the vessels of the vessels. The vasa vasorum can get occluded by spirochete, which is the Treponema pallidum, part of the syphilis causing agent, and they can lead to some kind of a tree bark appearance and just complete annihilation of the tunica intima. We talked about all of this in pathology, so if you want to get some more detailed information, watch the pathology videos. In terms of syphilis-induced aneurysm, the clinical presentation will be signs and symptoms of aortic regurgitation, which we spoke of, and it will also be signs and symptoms of space-occupying lesion. Because now if this aneurysm gets large enough, it can affect different vessels and different things within that region, especially in the mediastinum. It can affect the phrenic nerve, which can lead to voice changes, it can lead to hiccups, and things like that. So let's continue. In terms of management, you just want to treat the underlying disease for aneurysm relating specifically to the syphilis infection. The arteriosclerosis, again, the etiology here, basically, there's a lot of things that has to do with, that causes arteriosclerosis. Vasculitis, we talked about, such as polyarteritis nodosa, Kawasaki's disease, we said, are some of the things that may cause some kind of an aneurysm. Then there are these iatrogenic causes, such as chronic renal failure in patients who are on dialysis. That's congenital diseases or defects. Aneurysm will be things like buried aneurysm, maybe specifically associated with adult polycystic kidney disease. And this aneurysm usually appears in the circle of Willis, especially at the anterior communicating branch. Right. So let's Ehlers-Danlos syndrome and Marfanoid syndrome. These are collagen vascular problems that may be associated with forming aneurysm as well. Of course, because the vasculature is composed mostly of collagen. So if you have collagen vascular problems, then you can have aneurysm formation. The most common site for aneurysm that you have to memorize, and I think you should know, is the abdominal aortic aneurysm, which is just above the vessels that supply the kidneys, right around the area where you have the superior mesenteric artery coming from. The reason why the AAA is more important is because the AAA has a very high mortality rate. Clinical presentation for most of these aneurysm, the main thing to get is that the individual may have pulsating abdominal mass. Even on auscultation, you may hear different sounds, abdominal bruits and things like that. Most frequently will present in an older person. And the question that they like to ask, and I did not put that here, is a 70-year-old male who has a 30-year plus history, 30-pack year of smoking. They will ask you what will be the next step. The U.S. Task Force for Preventative Diseases has some recommendation to screen everybody for aneurysm after a certain age, I think after age 65, who has had like a 30-plus years smoking or something like that. So more commonly, when the vessel weakens, that leads to risk for dissection. Dissection is where most of your questions will come from when it deals with aneurysm. Aortic dissection, there's different types of dissection. There's type A and type B. Type B has to do with the descending dissection, which essentially we're talking about the descending aorta, and type A has to do with the ascending aorta, which is just fresh coming out of the heart. So if there's a dissection happening there, the blood can regurgitate back to the heart, and that frequently will get into the pericardial sac, and that can lead to pericardial tympani. And of course, tympani will present with signs and symptoms of hypotension and muffled heart sound and JVD. In the etiology for this, again, we talked about a lot of things that may cause it. We said individuals who have Marfan syndrome is classic to have this type of aneurysm and or dissection. Individuals who have other coronary artery diseases can also have it, especially people with pregnancy. But the most common cause in 90% of the cases, if they were to ask you and you're unsure, is people who have hypertension will be more prone to getting aortic dissection. Usually affects male who are in the age about 50. So male at the age of 50 with high blood pressure, so you're thinking African American males will be more prone to getting aortic dissection. Type A is the one you want to be concerned with because it leads to backflow of blood around the heart. The pathophysiology here, I have a lot of notes here, but let me keep it simple. Rupture of the aneurysm leads to regurgitation of blood, which means blood will pocket around the heart, and that can lead to tamponade. That's as much detail as you should get from here. In terms of the management, you want to give the patient IV fluid or en route to doing a pericardiocentesis, which is your definitive form of treatment. But giving IV fluid essentially prevents cardiovascular collapse. Next, we're going to focus on vasculitis. Vasculitis has a lot of details. It's a lot of details here. But again, there's a couple of vasculitis that I have a star on, and the ones that are heavily tested and their clinical connection, we're going to talk about that. You have vasculitis can be grouped into different categories, from large vessels to medium vessels to small vessels. The large vessel vasculitis are these two ones here. Giant temporal arteritis, which is a big vasculitis that affects the temporal arteries, especially that has a connection to the arteries that feeds the eye with blood. Then you have Techiasus, which is also called Pulseless disease. You have polyarteritis nodosa. You have thromboangiogenic obliterant, also called Berger's disease. You have Wegener's disease, which is now called polyangiitis with granulomatosis. You have microscopic polyangiitis, and you have Kawasaki's. Church-Strauss is also a small vessel vasculitis, and that likes to appear frequently in pediatric session. In giant cell temporalitis, its clinical presentation will be usually an older female who presents with signs and symptoms of headache. They may have a distension of the temporal vein. They may have pain on tenderness in these different areas, and they may be presenting with signs and symptoms of transient blindness. The diagnosis for an individual who has temporal giant cell arteritis is to do biopsy. You do serial biopsy because the vasculitis has granuloma pockets that are in different sections within the vessel. So you do serial. In terms of the management for them is that you want to make sure you give them steroid. Now this is where your questions will come from. That's the reason why these have a star. You give them cyclophosphamide, which is high dose corticosteroid, to prevent them from getting blindness, even in the process of you doing your biopsy to figure out if this is actually temporal giant cell arteritis. Now, when you give them steroids, the patient, in some cases, too much use of steroid can cause myopathy, which represents with signs and symptoms of aching and pain in different parts of the body. Now, the important thing here is that the patient who has this vasculitis have a strong association with what is called a polymyalgia rheumatica. Polymyalgia rheumatica is a disease. It's an autoimmune disease that also presents with aching, feeling in joints and stuff. Now, when you have myopathy that presents with joint aches and pain, and you have polymyalgia rheumatica, which also presents with the same thing, in the context of a person with giant cell temporal arteritis, the question will ask you which one of these are likely the culprit of this person's new symptom. And their symptom is purely going to be on the joints, aches, and pain. You need to discern if this is due to the steroids or if it's due to the complication with polymyalgia rheumatica. That's how the question is going to trick you. Now, the last thing to understand is that both of them will have an elevation in the ESR, but in the case of myopathy, the patient may have an elevation in the CPK, okay, because this is a muscle problem, whereas in polymyalgia rheumatica, the CPK will be normal. Let's continue. Individuals will have blindness if this is not treated and the blindness is not reversible. We already talked about polymyalgia rheumatica. We say that the next vasculitis is called Pulseless disease. This is a vasculitis Techiasu, usually seen in Asian women. The problem is that this is a large vessel vasculitis, tends to affect the aorta. The key things to get from here is that it presents with myalgia. Individuals will present with constitutional symptoms, which is night sweat, fevers, and weight loss. That's the same symptoms you see with people with TB, same symptoms you see with people with different types of cancers, and then also with people with Hodgkin's disease. Let's continue. Then we have polyarteritis nodosa, which is very high yield. This is one of the vasculitis I'd like to test. This is a medium-sized vasculitis. It can have systemic transmural necrotizing vasculitis, in which case, if you do a biopsy, you will see fibrinoid necrosis in most of the vessels that are affected. The key thing to note is that it can cause systemic vasculitis and aneurysm in just about everywhere in the body, but it spares the lungs. So let's put a start to that. Aneurysm affect in the GI tract, which can lead to melena. It can affect the heart, which can impair and cause infarct and ischemia. It can affect the renal system, which can lead to renin problem, can lead to hypertension. Let's continue. In the clinical presentation, patient will have strong association with superior mesenteric artery. This is where you have that aneurysm affecting the SMA, which means that you have deprivation of blood to the watershed zone. We talk about the splenic flexure and the colic flexure, and those areas which receive blood last will lead to some ischemia and necrosis, and that can lead to melena. The classic thing that I also like to be tested is association with hepatitis B virus. In 30% of the cases, polyarteritis nodosa may be associated with hepatitis B virus. Next is thromboengenic obliterance, which is also called Berger's disease. Again, we're not going to get into a lot of details here. The etiology here is due to a person who has type 1 hypersensitivity reaction to tobacco products. So those who are smoking are more frequently the ones that get this disease. The pathogenesis is such that this thrombosis can cause an acute and or chronic effect on the vessels, and by doing so, it can lead to complete occlusion, can lead to ischemia and necrosis, and of course, in the person's fingers and things will start to fall off. The diagnosis is do biopsy, just like any of the other vasculitis. You want to do biopsy to check for any of these things. And since it's a vasculitis in the inflammation process, you want to expect more PMNs and macrophages at the site. Clinical presentation, the person will present with signs and symptoms of claudication. This is the only vasculitis we talk about when we say it has a strong association with Raynaud's phenomena, where there's purplish discoloration of the skin, especially in the fingers or the distal extremities that receive blood last. This poor circulation can lead to pretty much severe pain. It can lead to microabscesses, and these microabscesses can lead to ulceration, which eventually will lead to a person losing their hands, losing their fingers and toes. The management, tell the person to stop smoking. If they've gone to a certain point, of course, they will lose their fingers or toes, but the best you can do is to tell the person to stop smoking. The next one is Wegener's, also called the polyangiitis with granulomatosis, which is a very high yield vasculitis. The pathogenesis for Wegener's is such that 95% of individuals have C-ANCA positivity, and in Wegener's, we have this necrotizing granulomas, which can affect different parts of the body. It can affect the upper respiratory tract, starting with the nose. It can affect the lower respiratory tract, which is the lungs, and it can affect the kidneys. If you do biopsy of the kidneys, you see a person may have a crescentic appearance of the glomeruli, which is also characteristic of Wegener's. Clinical presentation for a person with Wegener's disease, they may have persistent pneumonitis. They also have effect on different organ system. In terms of the upper respiratory tract, they may have chronic sinusitis. We talked about the mucosa membrane area will be affected, and of course the renal will show renal disease, which we said the person may have crescentic appearance on biopsy. Diagnosis for Wegener's, you want to do stains. You can do silver stain, you can do acid fast stain. In terms of the management for Wegener's, you can use high-dose cyclophosphamide. Complication if untreated, within 1 year, 80% of people are expected to die. So Wegener's is very, very high yield from that standpoint. The next one is microscopic polyangiitis. It's a small vessel vasculitis. It's not very high yield, but it's a necrotizing vasculitis that mimics polyarteritis nodosa. Small vessel vasculitis, as we said, it can affect the lungs. It can affect different areas. There's a mnemonic for it called BLINK: the brain, the lungs, the intestines, the nervous system, the kidneys, the BLINK. Now we talked about polyangiitis with granulomatous, Wegener's, associated with C-ANCA. This one is associated with P-ANCA in 70% of the cases, and is not associated with hepatitis B. Then you have Kawasaki. Kawasaki is high yield, and this is the one that they frequently would test you on. And it affects usually children of Asian descent, Japanese specifically, usually less than the age of 4 or 5. The pathogenesis is such that this is a type 2 hypersensitivity reaction. Now remember, Berger's was a type 1. This one is a type 2 hypersensitivity reaction. The etiology is really unknown, but it affects the medium vessels, especially the coronary vessels. Then the patient may present with classic signs and symptoms of fever and conjunctivitis and strawberry tongue and skin rash and edema in different parts of their body. In terms of the major complication, the ones we give a star to is its association with coronary artery aneurysm, because it affects those medium-sized vessels, especially those ones that supply the heart. This is where the high yield concept comes from. And they will ask you what will be the next best step in these individuals who have this disease. Of course, you want to treat it, but immediately you want to give aspirin, because aspirin is to prevent the coronary vessels from having major spasm and major problems that may cause a heart attack. There isn't a lot of scenario in which a 5-year-old child is going to have a heart attack. There isn't. If a clinical veneer reads such a case, it's going to be Kawasaki disease. Let's look at some pathology image here. So here is a young child, probably 4 or 5 years old. You can see the strawberry tongue appearance. Here is a young Asian child, also probably around the same age. You can see all the different signs and symptoms: the edema in the feet, the conjunctivitis, the strawberry tongue. You can see the edema in the hands and feet. You can see different skin colorations. So all of this is just to show you that this specific image looks like scarlet fever in terms of the strawberry tongue, and the skin changes might look like scarlet fever as well. But read the clinical veneer carefully, because if they are talking about a 5-year-old kid, doesn't matter. You have to pick Kawasaki disease and you have to move on. In terms of the management, the two management type we talked about, we say give IVIG, and then you can give aspirin. Aspirin most frequently will appear on your exam as what would be the next best step. You can give aspirin. It takes a few seconds to give aspirin. when they talk about cure or treatment, then you might be considering IVIG.